Welcome to the NWA-ETC Project Echo. I'm Kent Unruh, and I'd like to turn it over to Dr. Brian Wood, our medical director, to introduce our guest.
I'd like to thank Dr. Susan Graham for coming back to do part 2 of her series on treatment in resource-limited settings, and I will just turn it over to Susan.
I don't know how many people are on who missed last time, but we'll just sort of jump in. I've got a little bit of review from last time before we go forward. For those of you who may not have made it last time, I'm a member of the University of Washington Kenya Research Program here, have been involved in ART treatment programs in Kenya at a number of sites, mostly sites serving female sex workers and men who have sex with men, so sort of high risk for HIV transmission. So I will go on today. Yesterday we talked a little bit about who was eligible for treatment, how that was decided in different countries, how the WHO criteria have changed over time, and initial regimens. So today I want to focus more on what happens after treatment is initiated. I'm going to start with the initial regimens and review that quickly. Then talk about monitoring treatment, diagnosing failure, and the options available for patients who have treatment failure. And then talk a little bit about the problems of not using viral load and not having access to drug resistance testing in these settings. The initial treatment regimens, as a reminder, have sort of morphed over time. In the early WHO guidelines, 2006 being one of the earlier ones, the recommendation was for a thymidine analog as well as 3-TC and either efavirenz or nevirapine. And at the time, nevirapine was used more often for women because of concerns about fetal toxicity. And there were some other regimens, including for HIV/TB, triple NRTIs was used at that time as an approach because of concerns about dosing rifampin with an NNRTI. So as things have evolved, they've actually become a little more streamlined. So you see that by 2013, we really have one preferred regimen. It is the regimen that was always used for hepatitis and HIV co-infection. But so TDF, 3-TC, and efavirenz is now preferred in the face of very little data showing that nevirapine actually caused fetal injury or malformations. Efavirenz is now recommended even in pregnancy. And this sort of simplification of choices has really helped in terms of drug supply, monitoring, and access, which often ART programs are run by nurses, clinical officers, which is like a PA in most of these countries, and not really by physicians. So by 2013, we're really at sort of a Truvada efavirenz, or I guess that's a tripla sort of regimen, with AZT as the preferred alternative to TDF if not usable, and nevirapine still an option, although it will probably become less widely used. And finally, we have discontinued stavudine, which was on there for quite some time and the cause of a lot of toxicity. What happens once patients begin these regimens? The current WHO guidelines for monitoring treatment are to check a CD4 count every 6 months. This is largely happening, although not always. It's more common in urban settings. Some of the rural settings still do not have access to CD4 counts or have very irregular access to CD4 counts. Viral load testing is now recommended by the WHO 6 months after initiating treatment and every 12 months thereafter, but if available, really has to be added. Generally, countries that are somewhat more wealthy have started to roll out viral load testing. It's available in South Africa in some settings, but a lot of countries absolutely don't have the lab facilities or the resources to do viral load testing. Sometimes, patients who were seen in resource settings or CDC-funded settings are more likely to have had actually some viral load monitoring. The only monitoring for toxicity that is recommended currently in the WHO guidelines is a urine dipstick for glycosuria and serum creatinine. I'm sorry, I didn't put it, that's recommended kind of yearly, but if feasible. And again, this is not a test that's widely available. Even the urine dipsticks are not commonly done, and that's fairly new in these guidelines that they're recommending a urine dipstick for glycosuria to look at TDF toxicity. Many people are not yet aware of them in my experience of that recommendation. So other tests are basically symptom directed. If somebody has hepatitis, you check their ALT. If somebody looks anemic, you check their hemoglobin. But there is not a lot of access to basic biochemical labs in most resource-limited settings, as people have discovered from the Ebola epidemic as well. In terms of diagnosing treatment failure, there's a little bit more pressure now to use a viral load in that setting. So there's this idea that you're going to use targeted viral load testing. If you really have to go through a lot of effort to get a viral load, you're going to pick certain patients who you suspect of failure and just test them if you can. And this sort of preference for viral load testing is new. It's just since the 2013 guidelines, whereas other methods that I'll talk about below were preferred before that. Failure is diagnosed as over 1,000 copies per mil on 2 consecutive measurements with 3 months in between, with adherence support to make sure that they were actually taking the regimen. That is kind of as good as it gets now in these countries. If you have access to this, to have 2 viral load tests. Often one test is all you get, and there's a debate about whether the patient is adherence and what to do. If the viral load is not routinely available, as it isn't in most places, CD4 count and clinical monitoring are still used. Clinical failure is really hard. So a new or recurrent clinical event indicating immunodeficiency. So this could be TB while they're on treatment. And it's very hard because sometimes the CD4 count doesn't wobble and they have a suppressed viral load throughout. So clinical failure is only sort of weakly associated with treatment failure from a virologic standpoint. So it's a little tricky. Immunologic failure, it may be slightly better. CD4 count falling to baseline or below is thought to be failure, or someone who has persistent levels below 100. And often it's either failure or an intervening illness, or it could be that the patient's just not taking their drugs. So it gets very difficult to diagnose treatment failure, and for that reason it is underdiagnosed to a large extent. And remember that resistance testing is simply not available. It is mentioned in the WHO guideline as something you could do at baseline or at treatment failure, but it is not available in most resource limited settings at all. It's a research test, basically. So second-line regimens basically build on the fact that first-line regimens use NNRTIs. The second-line regimens use PIs, which are more expensive drugs. And right now in 2013, the preferred PIs are fixed-dose combinations of atazanavir, boosted atazanavir and boosted lopinavir, and because they're heat stable. And people can store those in their homes where they don't have refrigeration. If D4T or AZT was used in the first line, then one is supposed to switch to a TDF3TC combination. Conversely, if TDF was used in the first line, then you move to a AZT in the second line. And the thought is that there's just going to be enough NNRTI activity there to help support the PI, even if there's some resistance. When hepatitis B is involved, often you're viewing AZT, TDF, and 3TC in the second line regimen. So that is sort of what people will be on generally if they switch. And of course, there are people who have reactions to NNRTIs or have hepatotoxicity, other reasons for switching to a second-line regimen besides failure. So it can get a little confusing about why people are on a certain regimen. And again, the problem with hepatitis, as I mentioned last time, is that hepatitis serologies are not widely available. So in the majority of patients, we don't know if they're co-infected, despite having recommendations. Third-line regimens are kind of hypothetical entities still. They were mentioned in the 2006 guidelines, but the focus there was that that patients should just continue their failing regimen because that was better than nothing and often would prevent some clinical events. And if there was clear failure, basically palliative care was suggested. In 2010, they first mentioned third-line regimens and said that they should include new drugs likely to have activity, which would be either sort of second-generation NNRTIs or PIs or integrase inhibitors. Again, not widely available. A lot of countries didn't have the funds to move to do these. And given that people are very rarely switched to second line, being switched to third line is a very rare event. In 2013, there was more of an emphasis on stressing that these drugs were available, so that basically they said that programs should have policies. In Kenya, the policy is that you email the National Ministry of Health coordinator and you present the case history and are approved or not. So far we have not successfully advocated for a third-line regimen that I've seen. It's still, there is the thought that raltegravir is around, and the drug company, there may be some compassionate use sort of raltegravir that will become available, but it's not happening in large numbers, certainly. So switching and misdiagnosis. So the result of these policies, a lot of people are doing well on ART, but at the same time, this is, as most people would imagine, is somewhat suboptimal. Not having virologic testing really means you're guessing at whether or not they've failed treatment. Clinical criteria have a sensitivity of 11% and a positive predictive value of only 45%. So they're not very useful. And honestly, immunologic criteria are not much better. They may have a slightly higher sensitivity on average, but again, the positive predictive value is very low. So what can happen if you are very closely watching people and monitoring is that you're ending up switching people onto second line before they've actually failed. And if you do viral load testing on those that fail, up to about half of them will actually have suppressed viral load when you're switching them because their CD4 count wobbled. So it's a bit difficult. Despite that, where this would suggest that more people would be going on second-line therapy unnecessarily. But in fact, what you actually find is that very few people are switched to second-line therapy, either because there's the thought that they aren't adhering well and they just need to try harder, or because people have had experience with sort of mild clinical illness and they aren't confident that whatever happened warrants a switch. So it's very confusing for people, and it's often confusing for patients who get blamed for not trying hard enough at the time when this comes up. Switching and resistance. So what ends up happening, and it sounds like you all discussed a case last week where a patient had multiple drug resistance mutations. So because you don't have virologic testing and because you don't have access to drug resistance testing, a lot of people are just continuing on this first line therapy until somebody really bites the bullet and says, gosh, I think this is it. Or really has looked at the chart back far enough to say the CD4 count is now below baseline. Remember, we're in paper charting. We're not in electronic charting in most places, so it's hard. So when people do fail, the majority have multiple drug resistance mutations and at least dual class resistance, so NRTI and NNRTI when they're diagnosed. Very many patients, this is from a study by Rafe Hamers where they actually looked at 12 months after initiation and did drug resistance testing on everyone. And more than half had M184V, a lot of them K103N and Y181C, as well as G190A, a little less commonly. But NNRTI resistance is very common, associated with treatment interruptions. And M184V is very common. TAMs seem to accumulate over time, and now there's increasing K65R, especially with the tenofovir use. So what does all this mean? We're sort of a little in the dark. There, there is probably increasing transmission of drug-resistant virus. I'm doing an analysis now and didn't put it on a slide because don't quote me yet, but it looks like we're estimating the median duration of resistance in plasma at switch to second line is about 2.5 years. The median time of resistance in genital secretions is about 2 years before they finally switch to second line therapy. So this of course creates a situation where transmission of drug resistance virus is becoming increasingly likely, and there's some evidence that that's the case. And of course pretreatment resistance is associated with an increased odds of virologic failure and a lower CD4 count increase. It does something, and that's one of the reasons you do see some clinical impact. It's just suboptimal. Switching in survival, so yes, this does make a difference for survival as well. So this is a study that just came out in AIDS of 823 patients who had confirmed virologic failure, and the cumulative incidence of failure. Let's see, how does it work? It was those who had failed immunologically and those who had not. Those who had failed immunologically were more likely to die before the, during follow-up. Those who had no immunologic failure but had virologic failure were a little less likely to die. So it does show that immunologic failure may help you to a certain extent if you identify that you may decrease mortality, but it's very difficult to follow, and sort of when you don't know the viral load, you have an increased risk of dying over time. I'm going to sort of wrap up. Basically, the scale-up has been very successful, and this public health approach where you're using task shifting and you're using sort of a very unified regimens has worked. It's a great way to get treatment to a large number of people at a pretty low cost, but monitoring treatment without viral load testing is very frustrating for clinicians who often have nothing to base their switching on, or are afraid to implement the guidelines as they are. It's frustrating for patients who get blamed for not adhering correctly, and that's one of the reasons they're getting sick, and they're just told to try harder instead of switching often. It's a very algorithmic treatment approach, and probably does lead to differences in outcomes.